numb? S. Speech. Is the speech strange or slurred? T. Time. What time did the symptoms begin? Take note and take action now. Good afternoon to the listeners on DBS, Kyrie FM, Q95 and Vibes Radio, and to the viewers on DBS Radio, DNO, and the Ray Astor Foundation's Facebook page. And welcome to the Ray Astor Foundation's panel discussion on the topic, dealing with stroke in Dominica. My name is Monel Alexis, and I am your host. Thank you for joining us, and thank you very much for your patience. Meet today's panel.
Good afternoon, Dominica. Thanks for having me, Riasta. I'm Dr. Monroe, a medical officer at the Accident and Emergency Department.
Good afternoon, everyone. I am Portia Mead, internist here at the hospital, specialist in internal medicine.
Good afternoon, everyone. My name is Cornelia Abraham. I am the ICU trained nurse and the supervisor of the intensive care unit. I'm happy to be here this afternoon.
Good afternoon to everyone. My name is Reverend Dr. Reginald Lafleur, a Chris by profession. I'm happy to be part of the panel here.
And I thank each and every one of you for joining us, and thank you very much to our audience for being part of the panel this afternoon. Today's discussion will not exceed 1 hour, so let's begin. So the first question to the panel, please offer your opinion on the topic, dealing with stroke in Dominica. Dr. Monroe.
Firstly, let me put this out here, the disclaimer. I'm not benefiting anything from Riasta or any other organization. So today I just want to be frank, have a decent conversation. The stroke situation in Dominica is a very serious one that we need to take seriously. It affects every one of us in one way or other. So let's just come with an open mind and let's just participate and be honest with each other.
Dr. Mead?
Well, being in the hospital, working on the medical wards, which is the area where we do receive the patients who have had strokes, I can honestly say that, like Dr. Monroe, the stroke situation in Dominica is a frightening one. We've had an increase in our number of patients who are diagnosed with strokes to the point where we are at 1 to 2 strokes per day, which is 1 to 2 too many. Before we would see stroke patients, and I'm speaking before Erica, Tropical Storm Erica, Hurricane Maria, we would see perhaps 2-3 per week, but right now we're up to about 7 to 14 new and old patients with new strokes at this current time. So it's too many. It's too many stroke patients.
Sister Abraham, your thoughts dealing with strokes in Dominica?
So the topic is a very relevant topic because we are seeing a lot of persons coming down with strokes.
Young, middle age, old age, and especially where I work in the ICU, we see a lot of patients coming down with the worst ones, the hemorrhagic strokes, and I think that persons should be aware and should be knowledgeable of, what it is and how to prevent it. So it's a very relevant topic, and I'm happy that we're having the discussion here today. Reverend Lafleur.
It's a very relevant and also very important topic because that was the last thing I ever imagined would have happened to me. I always thought when it came to stroke, it was people of an older age, and never realized that at my young age it could have happened to me. So I think the topic is very relevant and very pertinent.
All right, well, thank you very much for sharing your opinions on the topic. And we'll start with you, Reverend Dr. Reginald Lafleur. You would have suffered a stroke in 2011 and a second one in 2021. Walk us through 2011, your experience.
Well, I begin by saying I'm both diabetic and hypertensive. The first stroke in April of 2011 occurred whilst I was celebrating Mass on Sunday morning. Suddenly, I was preaching and I felt that my speech was blurred. And then I was losing concentration and I felt dizzy. Then I vomited. And after having vomited, then the parishioners came to my rescue and took care of me. But in spite of that, I still continued to celebrate Mass until it was finished, because I felt a little better after I had vomited. At the end of Mass, Nurse Justina Charles, who was the pal rep at the time, called the ambulance, and then they took me to the hospital. And there I was admitted. I stayed there for a period of 4 days. In spite of the fact that I stayed there for a period of 4 days and I was being treated, but it was noted that my pressure, my blood level pressure, was not going down at all, in spite of all the medication. And then after having stayed there for 4 days, my family decided to probably look further afield. And so they made provisions for me to go to Martinique. I went to Martinique, and it was whilst I was in Martinique that it was diagnosed that I had suffered from a stroke. Unfortunately, it was not diagnosed here in Dominica. After the experience in Martinique, I went to Barbados for a head scan, because at the time there were no facilities of that nature available in Dominica. So I did the head scan in Barbados, and after the head scan, I then further went on to the States. I went to the States because it was the same time I was graduating for my doctorate. And I remembered I was not able to walk as freely as I'd like to. And so I got to the States in a wheelchair. After I got to the States, I also went to some medical facilities. But I was determined, and I told myself that on the day of graduation, I am not going to graduation on a wheelchair.
You're going to walk.
Going to walk.
Wonderful.
And this I did, and I walked. And from that moment on, I have never been in a wheelchair. That was the first experience. The after effects of that were as follows: loss of memory. And one of the most frustrating things that I experienced was the fact that I am in your presence. I've known you from before. I can't remember your name. And I cannot let you know that I'm talking with you, but I do not know your name.
Oh.
And that was very, very frustrating. Sometimes I would probably leave, and as I'm going to, let's say, Portsmouth. When I got to St. Joseph, I would completely forget where I'm going to. And so I had to stop and then recall, and then from there, I will remember I was on my way to Portsmouth. So that, for me, was the experience the first time.
And the second one, briefly.
Second one, briefly, was that I started having double vision. I was driving on the back road, and I was seeing two cars. So at the time I realized that, I decided, no, I need to go and park that car. Right? I went home, I parked the car, and then my speech also was blurred, my vision also, and then I called my doctor, Dr. King, and she came in that night and saw me, and she told me I need to go to the emergency department immediately. And that, in essence, was a synopsis of the second stroke.
But did you know that you were experiencing a second stroke?
Yes, I did,
You knew.
because I'd known from the first one, I'd seen the vision, I'd seen the symptoms, and so I knew from that experience it was another stroke.
Last year, 2021, this year, 2022, how are you feeling now?
Well, on top of the world.
So you're not having any symptoms of any
None.
stroke-related symptoms? You're
Physically, none at all.
physically, mentally,
None at all.
emotionally?
None at all. You would never ever say I had a stroke. You know, never, never. Twice, and twice, yeah. And that is because my attitude to life is very positive, you know. I do not allow anything to hinder me in life, you know. And so I continue to be very positive in my approach to life. And hence, that is perhaps the reason why I'm so happy. And secondly, I'm a man of God, right? And being a man of God, I place everything into God's hands.
Amen.
And God has promised to take care of me, and He is taking care of me.
Well, thank you very much for sharing your story with us,
Good.
Reverend Lafleur. We appreciate that very much. Let's get down into the meat of things. Let's talk stroke, dealing with stroke in Dominica. Dr. Mead, first question to you. How would you define the term stroke?
So a stroke occurs when the blood supply to a certain part of the brain is cut off. So that occurs either with a clot or a rupture of an artery in the brain. When it is a blockage, it is called an ischemic stroke. When there is a rupture of one of the arteries, it's a hemorrhagic stroke. So there is a difference between the two. The signs and symptoms are similar depending on the area that is affected by either one. They can have very similar signs and very similar symptoms. It is sometimes said that the hemorrhagic strokes are worse than the ischemic strokes, but we have seen patients who've had hemorrhagic strokes with just mild symptoms. However, we've seen patients with ischemic strokes succumb to their illness, right? So it all depends on where the stroke occurs, where the supply of blood flow is altered, is discontinued.
The causes. What are the causes of stroke? I recall Father Lafleur would have mentioned
Yes,
two.
yes. Those are the two main ones, right? Hypertension and diabetes. Hypertension and diabetes, unfortunately, cause a wide range of illnesses, and a stroke is by no means any different, right? The high intensity of the blood flow through the blood vessels causes either rupture, or if there is plaque formation within the arteries and the high pressure is constantly hitting that plaque, it eventually breaks off. And while it is in the larger arteries, there's no complete blockage in the flow. But once it continues its process along the circulatory system, it gets into the smaller arteries, it gets into the capillaries, and there is a blockage. Depending on the size of the clot, it happens right there in the larger arteries. In the case of a hemorrhagic CVA, a hemorrhagic stroke, it again depends on the area that is affected and the size of the artery that is ruptured.
Thank you, Dr. Mead. Dr. Monroe, you head the A&E department. From your experience, what is the main cause of stroke that you receive at the hospital?
If I just regress a bit, I want to reach the people out there. So if we try to talk simple terms, so that people try to understand as much as possible. So what Dr. Mead clearly mentioned is 100% correct, but I want to make sure that we reach everybody. No, pretty much, because it's very important, as we said at the beginning, stroke is something very, very important. So just imagine, for example, a blackout, or when light goes, as we say, right? So it all depends on the pole, the light pole that you get your supply from. So for example, you would see one street, a house, depending on the pole that supplies your house, is going to receive electricity, while the opposite house does not receive electricity. So it's the same thing Dr. May is trying to say. So it's like a blackout situation or lack of electricity, whereby from that blockage, everything else is affected. So we have to understand the blood flow is affected because of a sort of quote-unquote blackout. So, and again, the two main culprits are hypertension and diabetes. There are a lot more risk factors. For example, stress can cause strokes. We have the hyperlipidemia, the fat issues from our diets. Circulation issues, because again, circulation has to do a major role in the circulation of the brain. But the two main culprits that we have noticed are hypertension and diabetes.
Let's go back to you, Dr. Mead. Let's look at the symptoms, signs of a stroke.
It's funny you mentioned electricity, because I normally, when I'm explaining it to my patients, I normally use the Wasco.
Well,
right, but it's the same.
Let's talk symptoms. What are the symptoms of a stroke?
So a few of the early signs, right? There is mental confusion, difficulty with speech. Someone may be speaking to you, you're trying to speak back to them, to answer them, and the words would just not come out. Or if they ask you, your name or how you're feeling, you're unable to connect the dots and to respond adequately. So you may try to mumble something or answer a totally different question, right? So we see difficulty with speech, we see mental confusion. There is also, one of the other signs is numbness, symptoms and signs. Numbness to a limb on one side of the body. It could be either just the arm or the face or the entire face, arm and leg, usually on one side. And it usually happens on the opposite side of the location where the stroke actually occurs. Focusing on a particular object is difficult. So as Father mentioned, he had blurred vision, right? He had difficulty speaking. He couldn't remember where he was going when he was traveling. So to sum it up, difficulty seeing, difficulty with speech, with understanding, numbness or decreased power to one side of the body, usually the opposite side of the body. Some patients actually do have syncopal episodes or complete blackouts. So they may just faint.
Dr. Monroe, someone enters the A&E department with stroke-related symptoms. Walk us through the response from your department.
Well, when one comes through the department, you're first registered. Your vital signs are taken. So vital signs meaning that you check your pressure, check your sugar levels. We tend to keep you NPO. We start routine blood tests. If you're stable, or once you're stable, we try to get a CT scan done, which can then determine whether you're ischemic or whether you have a small bleed in your head. And from there, we interconsult with the medical wards or the surgical wards, and you're admitted.
In the case of second strokes, why is that? Why does that happen?
Well, pardon? As I said, I'm trying to make things as simple as possible to get to. When you have something brand new, it's brand new. If you have something used and banged up, it's not as new as before. So once you have the insult or the damage to your brain, for example, it's more likely that you can suffer a stroke once more. So if you don't have proper circulation and you have sort of the blood pooling, it's going to cause more damage. Because again, too, your vessels, blood vessels are weak from the hypertension that you had, uncontrolled pressures and so on. And with the pooling of blood, you can have the complications. Again, if I may go back to the light situation, if your light, no, I'm trying to make things as simple as possible. If your lights have gone, then your fridge is not working properly, the meat spoils, your fridge starts to defrost. So, for example, with the defrosting, water builds up in the brain, cerebral edema, swelling of your brain. So all of these things add up to getting a stroke, the higher risk of getting a stroke again. So once again, if we're not compliant, for example, the pressure situation, the sugar situation, all the complications secondary to your first stroke can lead you to getting a second stroke.
Do you have any statistics to share on second cases?
Well, second cases...
Or repeat cases?
Well, repeat cases, well, as I was informed, every 1 to 2 persons out of 5 readmitted to the hospital with stroke are repeat cases. So 1 to 2 out of every 5
Old patients.
of old stroke clients are repeat offenders.
May I also interject? So as Dr. Monroe said, a first stroke predisposes you or puts you at an even higher risk for multiple strokes thereafter. Just the fact that it happened once, it increases your risk 100-fold of having another stroke, albeit because of the underlying causes. So the damaged vessels along the brain system at any point, whether it is because of the high pressures or diabetes, because something we don't realize is that the high sugars, the high sugar level, high glucose level throughout the blood actually acts as a poison. So it damages the inner lining of the blood vessels. And once there's damage anywhere, there is a high risk of rupture or clot formation. It predisposes you, well, the patients, to strokes. So one stroke equals multiple strokes thereafter.
Thank you very much for that, Dr. Mead. Sister Abraham, what's your thoughts? What can be done to reduce the risk of a secondary stroke?
Okay, so having had the first stroke and knowing what predisposed you to having the first stroke, you can take precautionary measures to prevent you from having a second stroke, which includes taking your medications, your antihypertensives, that is, reducing your stress levels, checking your blood sugar, and anything else that will predispose you to having a stroke again, then you should take the precautionary measures to prevent you from getting a second stroke.
Okay, Dr. Monroe would have shared a few risk factors, but Dr. Mead, can you elaborate further on other risk factors for strokes?
The uncontrolled hypertension, uncontrolled diabetes are the two most common causes. There is also underlying damage that is done to the blood vessels, which would be vascular damage, and that also increases the risk. As Dr. Monroe said earlier, high cholesterol is another main one, and that is because the high cholesterol, the cholesterol molecules, they accumulate within the blood vessels, and at some point they break off. or at some point they damage the vessel where they are and rupture occurs, or if the plaque formation itself breaks off, it travels and causes strokes. A head injury can also predispose a patient to strokes. Family history. We've seen family history being a cause as well. High levels of alcohol intake, alcoholism, smoking, because all of these destroy the blood vessels. Once there's destruction of the blood vessels, then the risk of strokes are very high.
Thank you very much for that. Sister Abraham, from your experience, what are the main complications that are experienced by stroke patients on the ward?
Okay, so because of the fact that they have lost mobility, they have lost a lot of their functions, neurological functions, especially mobility, you find that they can't develop decubitus ulcers from being immobile in the bed because of loss of movement and sensation. They also can develop, some of them will develop some level of depression because of loss of independence. Having a stroke, you lose your independence from doing everything for yourself to doing pretty much almost nothing. Their immobility puts them at risk for developing pneumonia as well. So these are the most common complications that most of the patients can develop.
And what's the recovery timeline like?
Well, the recovery will depend.
I know that father would have bounced back quickly.
My recovery was within a space of a week.
1 week?
1 week.
Wow. But on average?
The recovery depends on the type of stroke, where the stroke occurred. It also depends on the availability of treatment. It depends on how soon you can get to treating the patient. It also depends on the management, the nursing care. It also depends on the patient's psychological status, because some persons, if they're in depressive states and they have lost the will to survive and to move on, then that pretty much can, hinder their recovery period. So it's multifactorial.
Okay, let's look at some statistic. Dr. Monroe, what is our daily average of stroke cases in Dominica, and what is the age range?
Well, I don't think I can specify the daily rate, but I have some data. Let me just begin by saying, generally speaking, the top three mortality, we have heart disease, heart attacks, these kind of things. We have cancers, and then we have cerebrovascular diseases. In 2020, the leading cause of death in Dominica, number 1, ischemic heart disease. Number 2, cerebrovascular disease. Strokes were second. Hypertension, 3, diabetes, 4, prostate cancer, 5. In 2021, complications of diabetes, 1, acute respiratory illnesses, 2, cerebrovascular diseases, 3. So that's 2 years running, second, third strokes. 4, hypertension, and 5, ischemic heart disease. So one of the risk factors, if you look about, is being male. I guess we can come back to that afterwards.
So men are predisposed to stroke? Is that what you're saying?
Well, we'll come to that after. But we are the harder hit ones, so all of this has to play a factor in us reaching out for medical assistance and so on. So besides that, the tendency, alcohol consumption, cigarette use, these also play an important factor in.
Let me cut you off for a little while. I've heard different things. I've been told that on average there are 2 persons in Dominica who get a stroke. Others would have said at least one person per day. Can you confirm if it's one a day or two a day? What the traffic is like at the A&E department?
Well, I have some statistics from June to November. And for example, we saw about 10,960 persons in the A&E department. And we saw about 85 persons with stroke-related symptoms, signs and symptoms. So that would break us down to about 14 persons per month, and that's about 0.47 per day. So that would calculate to about one every other day, pretty much. So at least one every other day was stroke-related. So if I may, in June, for example, there were 5 male, 5 female. So as about you, since you had cut me. So the trend, there's no real preference between male or female. We're all seeing male and female equal to suffering from strokes. So in June, 5 male, 5 females. Age range from 44 to 102 years of age. July, 14 female, 4 males. Age range 54 to 95 years of age. August, 11 female, 9 males. Age range is from 53 to 92 years of age. September, 6 females, 10 males. Age range 45 to 86 years of age. October, 5 females, 4 males. Age ranges 56 to 87 years of age. November, 8 females, 4 males. Age ranges 53 to 92 years of age. So we can see there's an even distribution between males, females, and the age ranges, from 40s to 100.
I noticed that there's somewhat of a fluctuation. What do you think is the cause of the increase in the cases that you're receiving at the A&E department?
Well, it's multifactorial. I believe one of the keys, as we can see, the male culprits are diabetes and hypertension. So the chronic non-communicable diseases has a main role to play in this. When it comes to compliance, for example, that's another issue when we're talking about the
What do you mean by compliance?
sticking to your medications. Sticking to your medications. I mean, we can, on this point, we can have a long conversation because we have to be honest with ourselves. Because if, for example, we know, talking in local language, sugar and pressure runs in the family, it's genetic, it predisposes us to having sugar and pressure. Now, someone may have had headaches before, went to check their sugar or pressure, and we were saying, was high, we're in denial. Or it's a one-time thing. When they come get treatment, we ask you to follow up, you don't follow up. So that one high reading does not go away. We walk with it. What we say about hypertension is a silent killer, right? A lot of us are walking around with high blood pressure, we do not know, and then something, God forbid, something happens, we come and we have hypertension. So it's not a matter of just a one-time thing. So we have to be honest. If we see the signs and symptoms, we need to act on it. We need to act on it.
And acting means?
Seeking medical attention, seeking medical advice. Again, as I said, it's a long conversation. We need to use our medical facilities, which includes health centers. Our family doctors, the health center doctors, are supposed to be your family friend. So it's not just a matter of checkups or changing up dressings or that kind of thing. We need routine checks. When they have their programs, we need to utilize the programs. We need to get their screens done, hypertension screens, diabetic screens, all of these things. So we men tend to be more resistant, reluctant, well, Dr. Bill is whispering, hard-headed, we need to get serious, okay? And I guess we may come to treatment, that sort of thing, and that is what happens. Most of the time, we tend to wait and see at home. So I have this weakness or numbness, let me wait 1 or 2 days and see if it will pass. I'm just equating it to one of the things that we always like to say, we have an ache, it's gas, that kind of thing. All right, so if we see something, let's act on it, not just wait and see. So the time that we wait, time is usually, they say time is money, but time is brain. Okay, so the longer that we wait, the treatment, no matter wherever you are in the world, the longer that you wait, the treatment may become futile. Okay, your chances are greater when you act faster, to identify your signs, symptoms faster, and you try to work on it. So if we wait and see, it's going to be into our. Okay.
So I just wanted to add that we have to bear in mind that an ischemic stroke does not always show up immediately on a CT scan upon arrival at the hospital. So what I'm trying to say is that you may have the signs and symptoms, yes, so we would diagnose you as a clinical stroke until the CT scan reveals the area that is affected. If the CT scan is done very close to the timing that the signs and symptoms started, the damage does not always show up on the first CT scan. So the numbers in casualty may not reflect the numbers that we get on the ward. So when the patients come in, the CT scan is negative, however, they are admitted to the ward simply because they do have the signs and symptoms. So it is a clinical stroke. The CT scan has to be repeated within 48 to 72 hours of that initial insult. And that is the time when we actually capture the ischemic strokes. The bleeding strokes will show up right away. Right? As soon as the symptoms start, the CT scan is done. Once there is a bleed, it shows up. But in some instances, the ischemics don't show up right away. So we do have on the ward, we might have a stroke every single day, but there are days when we have 2 or 3 strokes, right? So it does, for our numbers, it would be about 1 stroke per day at the hospital, well, admitted to the medical wards.
And that's 365 in a year, and that is too many for
our
Dominica.
population.
Definitely. Sister Abraham, somebody's on the ward. Nursing management is critical. Tell us, to your knowledge, what care is given to stroke patients at the ICU?
Okay, so at the ICU, we see the patients who suffer from the hemorrhagic strokes because these are the patients who will need mechanical ventilation or what we call life support because of the severity of the stroke. Because we have. So these patients will be attached to the mechanical ventilator, and we have to assess their respiration. We have to assess their level of consciousness. These patients, well, they are totally, they will be basically, well, I won't use the word dead, but not doing anything at all. Yeah, dependent. So we have to do everything for the patient. These patients, we have to feed them via nasogastric tube because for the reason that they are not able to do anything at all. They'll be catheterized. We have to monitor the urine output. We need to monitor the vital signs, especially the blood pressure, which was the major cause of their stroke. We need to give them the antihypertensives. We also need to give them range of motion, turn the patients every 2 hours. The diet that we give should be a very high caloric diet because remember they're in bed and they're moving, so we have to attend to their nutritional needs.
As you're on dietary, let's go into more detail. What is diet like for a patient who suffered a stroke?
Okay, so the diet will be a low salt diet because we need to maintain and keep the blood pressure down. It will be in a hemorrhagic stroke to a liquid diet because we feed them through a nasogastric tube, and also high protein diet as well because we need protein for the tissue and growth and everything. So basically it will be a liquid diet which is low salt and high protein.
And lifestyle, are there any lifestyle changes that would have to be made?
For you meaning for the ICU, the patients, or
for the ICU and once they would have left the hospital?
Well, the ICU patients, those who have left the hospital, very few because like I said, the patients who come to the ICU are those who suffer hemorrhagic strokes and start to say, but the recovery is not so successful as in a ischemic stroke. However, those who go home after, they're usually totally dependent on their relatives, family members. So the lifestyle changes really would be more for the family because they would need to be there to take care of the patient, continue to give them their physiotherapy, continue to give them their meals, to feed them via nasogastric tube if they go home with a tube. They need to continue giving them the range of motion exercises. So it's a continuation of the care from the ICU that will be transferred to the family and the relatives because these patients are totally dependent on the family.
And Father Lafayette, did you receive the support from family and friends to aid in your recovery?
I did.
Or we want to just did everything on your own magically?
Well, initially I got a lot of support from them, but then finally I had to do it all on my own. Maybe in comparison to other patients, was different. For instance, I never lost my appetite. Never lost my appetite. I continue to eat as well, you know. Slept well, you know. I continue to take my medication because every 3 months I would have to see the doctor. So there was that kind of lifestyle change.
Yes.
And ensure that you exercise every week. You know.
And it's working, well, it has worked for you.
It has worked.
Good. So Dr. Monroe, let me ask, what are your thoughts on taking aspirin or prescription medication to help prevent a stroke or a second stroke?
Well, the literature says that aspirin does assist in the management of, well, ischemic strokes or the transient strokes. But we have to be mindful the extent, if it's a bleed, if the person's on blood thinners, but the aspirin use has been documented as being beneficial in stroke management.
So you would suggest that someone would take aspirin to prevent a stroke? Is that what you're saying?
Well, yes, because for example, the first week or two, we can begin with the high doses and then taper down to at least 1 baby aspirin per day. Yes.
Let me rephrase my question. I'm scared of getting a stroke. Should I, on my own, as of today, take an aspirin 1 a day to prevent Monel from getting a stroke?
So I guess you want a long answer. Okay, so let's begin with our diet, exercise, lifestyle changes, and as I said, honesty with ourselves.
So yes or no, should I take the aspirin every day? Just tell me right now
aspirin,
so I can sort myself out from today.
Aspirin with other things. aspirin only is not going to prevent you from getting a stroke.
Okay. So do not, it's not, you're not suggesting that I
The
take
magic
aspirin.
pill is not the magic pill.
It's not the magic pill. Okay, so what about persons who rely on alternative medicine?
Oh,
Instead of taking the prescribed medication for hypertension, diabetes, high cholesterol, what are your thoughts?
okay.
And anybody on the panel, you're all free to join in on the conversation.
So this is another interesting one because, like I said before, I have a headache or whatever symptom I may have, go check out. I have high pressure. So I go home and I pull out my drawer with all these concoctions, this bush, and I take something and then I think it goes away. So again, taking the bush medication or the alternative medications has its pros and its cons. I reached out to a colleague and gave me some interesting statistics or common things that I asked for some common things. For example, the cayenne pepper. Let's begin with a few. It helps the circulation, blood flow, decreases inflammation. Nutmeg helps with the circulation, increases cognitive functions. The moringas, high in multivitamins and minerals, antioxidants. It brings down the sugar, the blood sugar. Turmeric, a good blood thinner, helps with inflammation. Garlic increases circulation, helps with the heart, immunity, decreases cholesterol, decreases coagulation of platelets, decreases blood pressure. Green pawpaw decreases blood pressure, circulation, cholesterol. The vervein, or famous vervein, is a blood thinner. But let me ask this question. How do we take it like a medicine, or do we take it once when we feel something? That's one question we have to worry about. So what's the frequency? What's the dosage? Because that's one of the troublesome points. I mean, everything, all pills come from some natural ingredient. But if I pick up a paracetamol and it tells me it has X amount of grams of this, X amount of grams of that, you know what is in there. But how do you draw the T's? For example, the vervein. I asked the question, how do you draw the vervein? We just put a small amount in a pot. I was informed, for example, 5 leaves to about a liter of water and let it draw. How do we mix it? How often do we take it? So we need to seek professional guidance if we're going down that road. And we have to be compliant, just like medicines. We have to be compliant. We have to know the proper dosaging, the frequency, how do we take it? It's not a magic pill, you take it once and then you forget it. So again, we have to worry about the genetics, your health condition, your lifestyle. If somebody is active as opposed to somebody sedentary, what's going to happen? How often do you take these things? So the alternative medicines, there are pros and cons.
So as the head of the A&E department, Dr. Monroe, would you encourage someone to go the alternative route to treat or prevent a stroke?
If they can ascertain the dosage.
Say that louder so they can capture you.
If you can tell me to take in the right amounts at the right time, yes. Until then, traditional medicine, where we can know, look at the back, at the label, and we know what to take and how you're supposed to take it.
Thank you for that response. Dr. Lee, your question, what is the biggest or most common misperception about stroke?
I think the biggest misconception is that it can't happen to me. That is one of the things that a lot of patients with high blood pressure, diabetes, high stroke, dyslipidemia, high cholesterol levels. I guess everyone always thinks, oh, well, you know, it's a stroke, I'm not 80, so, you know, it can't possibly happen to them. But it can, and it does. And we have seen patients in their 30s with stroke. We've seen patients in their 20s. Yes, it's not as common and there are underlying factors, but it has happened. Generally, yes, it's the 40-year-olds, 50s and above, but it can happen. It can very well happen to anyone, especially if you have these high risk factors, obesity, alcoholism, tobacco use, right? It can happen to you.
Well, thank you for these misconceptions. Let's talk about inspiring persons to take better care of their health. I know, Father, you're an expert where this is concerned. How would you inspire, motivate somebody to take better care of themselves?
First of all, I'll share my story with them. And by sharing my story with them, I'll help them to realize, as Dr. Mead said, it can happen to you at any age, you know, and in particular men, you know. And because of this, I have opened myself to other avenues of health so that I can be an inspiration to many more men, like not only diabetes, but also cancer, and these other areas. And healthy lifestyle. You know, I try to impress on them that it's important to live a healthy lifestyle, and above all, you must take care of yourself. If you don't take care of yourself, nobody's going to do that for you, you know. And that is what I have learned over the years, you know, that I need to take care of myself first and foremost, you know. So that is an inspiration that I use to share with other men like myself, because men, when it comes to medication and doctors, we do not like that at all.
I wonder why.
I think it's the male macho concept of ourselves, you know, that as a man you're not supposed to be sick. If you get sick, that is very childlike, you know. So a lot of men, I think I want to be an inspiration to them, to help them to understand, no matter who you are, you have to take care of yourself. And you can also get sick at any time.
Okay, let's talk treatment. It's almost where we have to wrap up soon, but let's talk prevention and then treatment briefly. Dr. Mead, how do we prevent? How do we prevent a stroke?
By keeping all of the items on the checklist in order. And by the checklist, I mean making sure that your body mass index is within normal range. Your weight for your height is ideal. Making sure that your blood level is within normal range. Your blood sugar, cholesterol levels, checking your family history. Making sure that you do not have any familial clotting issues. Right, so you should have a checklist. You should visit your doctor as often as possible. And sometimes I tell patients, going to the doctor is not only when you're sick. For people who have vehicles, they bring their vehicles to service every 6 months. And I've come across people who have not seen a doctor in years. So going to the doctor is to make sure that the vehicle of your soul is checked. Your kidney function tests are checked, your blood sugar levels, your fasting blood sugar, cholesterol, making sure that all of these items, all of these parameters are checked on a regular basis, at least once a year, minimal, right? Twice would be ideal, but at least once a year, getting these checked on a regular basis.
And Dr. Monroe, treatment. I know you mentioned earlier about the bush medicine, you're not too keen on that one, but treatment-wise, what is offered, what should be used?
Well, it again depends on the type of stroke that you've suffered, the extent, the seriousness of your injury. Because it depends, if it's serious, that means you have to be dependent on life support, everybody doing everything for you. But we have to, as I said, maintain your optimal blood pressures, the optimal sugar, glycemic levels. So we all have to play every ball on its merit. But we are supposed to maintain the vital signs as near to normal or normal as possible. So in terms of the blood pressure medications, the hyperglycemic medications. On the flip side, the lower pressures and the lower sugars as well causes damage as well. So we have to be mindful of that, because if your pressure is too low, it can affect the circulation to the brain. So we have to maintain, because one of the misconceptions that we have, yes, we come in with a high pressure, but we're not supposed to drop the pressure too low, too suddenly, okay, because that to itself can cause some damage. So just optimizing your blood sugar levels, your pressure levels, basically.
And Sister Abraham, I know persons come, they're at the ICU, they're anxious, they're depressed. What is done, what do you recommend for persons who are dealing with anxiety and depression post having a stroke?
Well, nurse will have to, we can refer them to a counselor, we can refer them to a psychiatrist. The nurse can offer some level of emotional support. There's also, if there are persons who have had strokes, we could probably, refer them to a support group, if there's a stroke support group.
You mentioned support. Is support provided for the family as well?
The support that can be provided is from where we have counseling, and if they need for a psychiatrist to come to see the family, yes, we have that available as well.
And persons leave the ICU with literature for aftercare. Does that happen?
No, we don't have that. No, we don't. Literature.
But usually they come to the ward from
Yes.
ICU. From ICU, they don't go home directly. From ICU, they go to the step-down wards, which are the medical wards. So from her, they'll come to us.
Yes,
And right. So we do speak to the patients. We inform them of the type of stroke that they've had and ways to prevent further stroke. So they do leave with not necessarily literature written, typed out, but conversations are had with them.
Well, thank you very much for that. Guys, it's almost time to wrap up our discussion for today, but not without your final thoughts. So I'll start with you, Dr. Monroe. Final thoughts dealing with stroke in Dominica and everything we have discussed. Or simply your advice to persons who are listening right now.
Well, again, as I said, let's be honest with ourselves. Any signs or symptoms, take it seriously and seek medical attention.
Dr. Mead?
Getting your annual health checks is certainly very important, at least once a year, twice a year. And sticking to the medication. If you are placed on medication for control of your blood pressure, your blood sugar, your blood cholesterol levels, it is important that you stick to it. And just all the lifestyle changes, the exercising, trying, different ways to relax and eat properly, fruits and vegetables and water.
Sister Abraham?
Okay, stroke is no joke. It can happen anytime to any one of us. So like the other panelist said, if you have a sign or symptom, don't hesitate to go to your health center or your doctor. Take the necessary actions. If you are hypertensive, please take your medication on time all the time. Reduce your stress levels. Exercise. Eat a healthy and balanced diet. Check your blood sugar. And do what you have to do to live a longer and productive life. You don't want to end up with a stroke. I don't think so.
Reverend?
Right, I would say the secret of your success is found in your daily routine. You can rise from anything. If you get tired, learn to rest and not quit. Start thinking in terms of wellness and not illness. And grow through what you have been. You are a warrior, and warriors don't give up. They don't back down.
Warriors don't give up, they don't back down, but this is our time, so we have to end our discussion. But I will not leave without saying thank you very much to each and every one of you for being part of the panel, which really appreciated your contribution today. Thank you very much to all those who are tuned in live on the DBS Carrier FM Vibes Radio and Q95, and also those who are live with us on DNO and also on the DBS Facebook page and on the Riata Foundation's Facebook page. This has been our pleasure, the Riata Foundation's, our pleasure to present this panel discussion to you. It is our mission to educate you to the point that you take the right steps to live a longer, healthier life. Remember, decision is always yours. It's your life. You have to want more. You have to want to live. And we are here to push you in the right direction. So if you have any questions or concerns, please reach out to us. Our Facebook page, Ray Astor Foundation. We are happy to, if you want to join our campaign, also reach out as well. My name is Monel Alexis. It has been my pleasure to be your host. I'm saying thank you very much for joining us. And do look out for our many other activities throughout the next few months. Good evening and thank you.